Bacterial vaginosis, BV, is a disturbance of the normal vaginal ecosystem. In a healthy vagina, lactobacilli dominate and produce lactic acid that keeps the environment acidic, pH approximately 3.8 to 4.5, acting like a protective barrier against opportunistic organisms. When this balance is disrupted, anaerobic bacteria such as Gardnerella vaginalis proliferate, similar to weeds overtaking a well-tended garden. The resulting shift may be asymptomatic or cause discharge, odor, and discomfort. Understanding BV as a dysbiosis rather than an infection helps clinicians focus on restoring the microbial equilibrium rather than merely eradicating a single pathogen. BV arises when the protective lactobacilli population diminishes, allowing anaerobes, most notably Gardnerella vaginalis, but also Mobiluncus, Mycoplasma heminis, and Prevotella species, to flourish. Factors that promote this shift include intravaginal douching, which mechanically removes lactobacilli, exposure to new or multiple sexual partners, which can introduce foreign bacterial strains, use of scented soaps or feminine hygiene products that alter pH, and hormonal changes such as those caused by oral contraceptives or intrauterine devices. For example, a woman who begins douching weekly may experience a rapid drop in vaginal lactobacilli, creating a niche for Gardnerella to colonize within weeks. Lactobacilli metabolize glycogen to produce lactic acid, maintaining an acidic vaginal pH less than 4.5. When lactobacilli decline, the pH rises, creating an environment conducive to anaerobic overgrowth. The excess bacteria produce metabolic byproducts such as putrescine, cadaverine, and trimethylamine, which generate the characteristic fishy odor, especially after sexual intercourse, when semen temporarily raises pH further. Histologically, the overgrowth appears as a thin gray-white biofilm coating the vaginal epithelium. Under microscopy, epithelial cells become covered with adherent bacteria clue cells. This altered microenvironment also compromises the mucosal barrier, increasing susceptibility to other infections and facilitating ascent of pathogens into the upper genital tract. BV is one of the most common vaginal conditions worldwide, affecting roughly 25% of women of reproductive age at some point. Prevalence varies by demographic factors. African American women report rates up to 40 to 50%, while rates are lower in Caucasian and Asian populations. Sexual behavior strongly influences risk. Women with a new sexual partner or multiple partners have a 2 to 3-fold higher incidence. Device-related risk is notable for intrauterine contraceptive users, possibly due to altered cervical mucus flow. Age-related patterns show peaks in the late teens and early 20s, correlating with higher sexual activity and contraceptive use. Clinically, BV may present with a thin, homogeneous gray-white discharge that adheres to the vaginal walls. The discharge often carries a malodorous fishy scent that intensifies after coitus or during menses due to pH fluctuations. Pruritus and burning are usually mild or absent, distinguishing BV from candidiasis. Approximately 30 to 50% of affected women are completely asymptomatic, discovering the condition during routine pelvic exams or prenatal screening. Practical cues include noticing a smell after a hot shower or when sweating heavily, as the volatile amines become more volatile in warm, humid conditions. Diagnosis relies on a combination of clinical criteria AMSLs and laboratory testing. The AMSL criteria require at least 3 of 4 findings. 1. Homogeneous gray-white discharge. 2. Vaginal pH greater than 4.5. 3. Positive whiff test fishy odor after adding 10% KOH. And 4. Presence of clue cells on saline microscopy. The whiff test detects trimethylamine production, a hallmark of BV. Nugent scoring of a gram stained smear quantifies bacterial morphotypes, large gram-positive rods equals lactobacilli. Small gram variable rods equals Gardnerella or Mobiluncus on a 0 to 10 scale. A score of 7 to 10 confirms BV. Point-of-care rapid DN attests are emerging, offering species-specific identification within minutes. BV is not formally divided into subtypes, but clinicians differentiate between primary, first episode, and recurrent BV, 3 or more episodes in 12 months. Recurrence often reflects persistent dysbiosis, reinfection from a partner, or incomplete eradication of bacterial biofilm. Management strategies differ. Primary cases typically respond to a single 7-day antibiotic course, whereas recurrent cases may require prolonged or combination therapy, adjunctive probiotic regimens, and behavioral counseling. First-line therapy is metronidazole 500 mg orally twice daily for 7 days, or 0.75% metronidazole gel applied intravaginally once daily for 5 days. Alternatives include clindamycin 300 mg orally twice daily for 7 days, or 2% clindamycin cream intravaginally for 7 days. For patients with contraindications, for example, alcohol use or pregnancy, or recurrent disease, tinidazole 2 grams single dose and high-dose metronidazole up to 2 grams daily have shown efficacy. Partner treatment is not routinely recommended unless a concurrent sexually transmitted infection is diagnosed. Adjunctive probiotic supplementation, Lactobacillus crispatus or rhamnosus after antibiotic completion may improve recolonization rates, though evidence is still emerging. Preventive measures focus on preserving lactobacilli and avoiding practices that disturb the vaginal milieu. Number 1, refrain from intravaginal douching or the use of scented soaps or whiff products. Number 2, wear breathable cotton underwear and avoid prolonged moisture exposure. For example, change out of wet swimsuits promptly. Number 3, use water-based unscented lubricants during intercourse. Number 4, limit the number of new sexual partners and practice condom use. Number 5, consider probiotic supplementation in high-risk women. For example, those with recurrent BV. Education about these modest lifestyle adjustments significantly reduces recurrence rates. When adequately treated, BV resolves within 1 to 2 weeks, and most women remain symptom-free. However, recurrent BV carries a 2 to 3-fold increased risk of ascending infections, such as pelvic inflammatory disease, endometritis, and postoperative surgical site infections. In pregnancy, BV is associated with preterm birth, premature rupture of membranes, and low birth weight. Moreover, the altered vaginal flora enhances susceptibility to HIV acquisition and transmission. Long-term prognosis therefore hinges on successful eradication, restoration of normal lactobacilli, and adherence to preventive strategies. Current research is exploring 3 main fronts: 1, probiotic therapy, clinical trials of vaginally administered Lactobacillus crispatus or oral Lactobacillus rhamnosus, GG, have demonstrated higher cure rates and lower recurrence after standard antibiotics. 2 novel antimicrobials, tinidazole and secnidazole, show promise against metronidazole-resistant strains, offering single-dose regimens that improve adherence. And 3 rapid molecular diagnostics. Point-of-care PCR kits can identify Gardnerella and other BV-associated species within 15 minutes, allowing targeted therapy. Additionally, studies on biofilm-disrupting agents, for example boric acid, lactobacilli-derived bacteriocins, aim to eradicate the resilient bacterial film that underlies